Thank you.
Thank you very much, Dr. Burgess. That was fantastic. Excellent. Very interesting study. We have a couple of questions. Professor Turner asks, what was the cancer risk by age 18, so pediatric onset cancer, and what was the cancer risk in those untreated with either biologics or immunomodulators?
So that's a very good question. We deliberately didn't include cancer risk in those patients less than 18 years of age because we were specifically looking at early adult data. So we do have that data available, but I don't have those numbers with me. But the numbers were very low in children less than 18. And the second question there, Eric?
Apologies. What about those untreated with biologics or immunomodulators?
Yes, with the Scottish Administrative Health data, we weren't able to link in medications because that data set only came in much later than the data we'd obtained. So we do not know which of those patients were on biologic and thiopurines. And of course, that information would be useful in the future.
Great. And I do want to ask a question myself, and then I know Mark has a question as well. Regarding the stroke risk, you related that to venous thromboembolic disease, which it may well be. And we heard earlier the higher risk in the PIBD safety registry, the SETI study, earlier this morning. So my question would be, did you separate out the stroke risk in people around the time of hospitalization to see if this might have been related to active disease, or is this an overall elevated risk of stroke?
So the numbers were so low, Eric, that we decided not to delve into it too much. And simply, these are patients who have presented for an inpatient admission with a primary code related to an acute stroke event. So whether that's related to their IBD and around a time of a disease flare, we don't have that information at present. But those numbers are so low, it would be difficult to pull out any more true advantageous sort of comparisons from that.
Thank you. And Mark, I'll let you ask your question, and we'll just remind everybody that if we don't get to your question, the presenters can respond to your questions in the Q&A box, so keep an eye out.
Yeah, thank you very much for your great talk and great insights. Can I ask you how much you think that treatment might impact on mortality? Because that's quite a complicated discussion when you have it with families. You can say inflammatory bowel disease as a cancer risk, for example. Treatment might reduce the cancer risk as well as increase it, if you see what I mean. I wondered if you'd got any insights from your work on that.
My feeling is that this work, Mark, shows that those patients who choose not to go down routes where they might be offered medications which can increase cancer risk, but which we feel will decrease their disease burden and their active disease flares, I think it helps some families make those decisions when you can clearly say, your risk of getting cancer from active disease is 50 times greater than the average population, whereas if we have you on thiopurines or potentially immunosuppressive medications, that risk is still higher, but only 5 times greater. And I think it's also useful to see that mortality risk with PIBD patients is there in early adult life. And so we assume that is due to active disease rather than just treatments. But of course, we don't know that. But I suppose any significant mortality risk early on in life is a big worry for families. So I think that does push families to accepting treatments more readily.
Thanks very much. So I'll introduce myself now as the co-chair. I'm Mark Beattie, a paediatric gastroenterologist from Southampton, and it's a great pleasure to be on this session. I would like to now welcome Professor Holm Ulrich, who is well known to you all as Professor of Paediatric Gastroenterology from Oxford, and he's going to answer a question we all find quite hard, which is the practicalities of diagnosis and treatment of very early onset inflammatory bowel disease. So Professor Ulrich, welcome.
It's a great pleasure to present at this 6th World Congress of Pediatric Gastroenterology, Hepatology and Nutrition on the practical approach to diagnosis and treatment of very early onset inflammatory bowel disease. We have reached this age of genomic medicine, and despite of having this scientific approach, it's still important that we remember one of William Osler's quotes to say that medicine is a science of uncertainty and an art of probability, and this is in particular true for an area like monogenic disorders and monogenic inflammatory bowel disease, where our knowledge base is restricted. We can differentiate the polygenic forms of inflammatory bowel disease, in particular Crohn's disease and ulcerative colitis, that present with a peak onset between the 20s and the 40s years of age, from the monogenic forms of inflammatory bowel disease, 75 plus orphan disorders that have a particular strong genetic impact and present typically in the first 2 or 6 years of age, area that we define as very early onset inflammatory bowel disease. What is common to those disorders is that there is a failure rate of anti-TNF therapies, immunomodulatory therapies in very early onset inflammatory bowel disease, compared to the more older and classical pediatric IBDs. And in particular, this is true for monogenic forms. This recognition that there are exceptional, extreme forms that are caused by gene defects in a single gene has led to a revolution in medicine, from identification of those extreme patients to the discovery of single gene defects, the use of exome sequencing, and then a transition towards clinical applications via targeted panel investigations, exome and genome screens, now to clinical applications as a standard of care. What has been observed is that there are distinct histopathological features in patients with very early onset inflammatory bowel disease. Here a study of Judith Kelson and others, where an increased rate of apoptosis, villus planting, or eosinophilia was observed. However, all of these findings are unspecific, and it's just a statistical association. Similarly, all the other typical criteria that we apply for the classification of IBD, be it phenotypic, radiological, or histological, are largely unspecific and will not help us in the differentiation between monogenic and polygenic forms of inflammatory bowel disease. And this has led to a concept where genetics is one of the key drivers in making the diagnosis, where we select patients with a high probability of harboring a monogenic variant, where this led to the use of genomics in the clinical field, identification of gene variants, and then with a mechanistic disease model, the application of disease and pathway-specific treatments, such as hematopoietic stem cell transplantation, specific biologics, or novel therapies, including gene therapy. What is important is that these research developments now enter the clinical practice, and as part of the Porto group of ESPGHAN and joined by some research consortia such as the Very Early Onset IBD Consortium, the Genius Group, or the Colosan IBD group, we evaluated recently the evidence to support clinical genomics, the patient selection, screening panels, preferred technologies, functional validation, and the role of a multidisciplinary team meeting, as well as the evidence for cost effectiveness. And that led us to a pathway towards the clinical use of genomics, where we start with an IBD assessment. We assess red flag signs, and then depending on the age of onset in a really probabilistic setting and the presence of additional factors such as red flag signs in the family history or in the clinical presentation or in laboratory findings, we then apply a multidisciplinary team approach, the use of genomics, be it panel, exome, or genome sequencing, the validation of those findings, and then start an team assessment to validate those variants and to plan the diagnostic and therapeutic care plan. As mentioned, there are red flag signs that are key to this approach. And one of the most important findings is if there is a patient with less than 2 years of IBD onset, if there are patients under 6 years of age, this is still very relevant, in particular if there is a family history, for instance, of other family members that are affected, consanguinity, or there is a relevant comorbidity or extraintestinal manifestation, such as infections, hemophagocytic lymphohistiocytosis, malignancies, or unusual findings such as multiple intestinal atresia. About 2/3 of those monogenic disorders have an age of onset under the age of 6 years as a median. However, we should remember that there is still a relevant number of disorders that have age and onset beyond this age, and we shouldn't exclude those patients from the diagnostic pipeline. What we do focus is on key features. And this is an exemplar. It's one of the classical defects, IL-10RB and IL-10 signaling defects where macrophages are not controlled because of the defective IL-10 receptor. And in this family, it's a consanguineous family. Multiple family members are affected. There is an extreme early onset under 1 year of age for family members, and one of these family members developed a B-cell lymphoma. Similarly, there are a number of gene defects that are not linked to classical immune-mediated disorders or immunodeficiency, and as an exemplar here is a metabolic disorder that you would not necessarily associate it with inflammatory bowel disease, a Niemann-Pick type C, a neurometabolic neurodegenerative disorder, where about 7 to 10% of patients develop intestinal inflammation. Again, red flag signs, 2 years of age onset, severe form of inflammatory bowel disease, developed in a splenomegaly. As a metabolic workup in this patient here presented did then identify plasma oxysterol levels that are abnormal, and then a subsequent diagnosis of Niemann-Pick type C. We have discussed in this position paper of ESPGHAN that there are a number of tests that are required. First of all, an classical IBD workup that includes endoscopy and relevant imaging, some essential blood work that includes, for instance, a full blood count, basic immune workup, for instance, inactivity markers like CRP, immunoglobulin classes, lymphocyte subsets, and then DHR assay to exclude chronic granulomatous disease. Other blood tests are often not required, and only if there are specific phenotypes. There is a basic infection screen that should be performed, for instance, to exclude HIV or tuberculosis as an infectious cause of intestinal inflammation, and stool tests similar to exclude bacterial or parasitic or viral infections, as well as a calprotectin to assess the disease activity. What becomes very clear when following the literature is to value the multidisciplinary team approach, and care of patients with suspected monogenic IBD should be taken in an MDT setting. Here's an exemplar from a patient from Oxford, where the age of onset was in the first years of life. Patient took a very severe course, developed immune symptoms like a severe lymphopenia or a congenital neutropenia. We did perform as part of the MDT and genome sequencing as part of the research, identified a variant in glucose 6-phosphatase, and then transitioned towards the clinical genetics. We collaborated with immunology and the hematology team, and this patient underwent an hematopoietic stem cell transplantation, after which the symptoms completely resolved. The diagnostic yield is highest when genetic investigations are performed in patients with an age of onset under 1 or 2 years of age. And similarly, if there is an family history, if there is a population structure, for instance, patients with consanguinity are enriched, and there is a clear center bias. So there is a clear difference whether you see a patient in a primary setting, or if there is a center bias and this patient comes from an immunodeficiency clinics. The diagnostic yield is depending on technology used. And as one of the exemplars is a study recently published by Alexio Muis group, where over 1,000 patients in a tertiary referral center have been investigated, and a rate of 3% rare variants have been identified, and in 1% there are disorders with a potential of hematopoietic stem cell transplantation. Now, these numbers sound very high. Not every center will have the same frequency. But what is clear is that we need to use these genetic approaches, since otherwise we might miss those patients. This is a study we performed as part of the Colors in IBD consortium, where we selected nearly 150 patients with very early onset IBD, where no Mendelian IBD was clinically suspected. We performed exome sequencing and identified in 4 patients in this group clinically relevant variants that led to hematopoietic stem cell transplantation and assessment. Unfortunately, 1 patient died during the diagnostic procedure. Now, are there preferred technologies? And currently, there is no preference if this is performed in the clinical genomics area. There are advantages and disadvantages for each of these technologies. Targeted panel sequencing with a high coverage and very cost-effective exome sequencing has a lot of advantages. Genome sequencing has an even coverage, very flexible to use, but expensive. The costs vary, and you will have heard that the costs obviously drop. Exome sequencing can be done with under 500 pounds or dollar. Similarly, genome sequencing under $1,000. In practice, these costs are much higher because of the analytic pipeline required. We have, as part of this clinical genomics position statement, evaluated the gene defects that should be investigated, and as part of a consensus process summarizing multiple reviews of research groups, we came up with a group of 75 monogenic conditions that should be screened. We have to be aware that not all of these disorders will appear in the 75 disease group, and it can take years to evaluate gene defects. In particular, functional tests are required that are not standard of care, and in particular, if novel genes are identified. And this is an exemplar that we recently published as a part of a research group where multiple international collaborators contributed, and where a gain of function in SYK was identified. The follow-up after the identification of the first patients took several years. Now, I like to summarize. We have now a clinical genomics position statement that highlights the importance of multidisciplinary team approach, where next generation DNA sequencing is highlighted as standard of care, in particular in infantile onset inflammatory bowel disease and in very early onset inflammatory bowel disease, if there are relevant comorbidities or extraintestinal manifestations. Beyond this age group, it's very important if there are extreme phenotypes. And we do not recommend the routine screening of all IBD patients based on the costs and the low diagnostic yield. This should be performed if there are relevant investigations that are, for instance, hematopoietic stem cell transplantation. We recommend panel sequencing. We recommend functional assessment. And patients in their family with suspected monogenic IBD should be offered the opportunity to participate in research studies. What is very important, and we are a World Congress of Pediatric Gastroenterology, is that local knowledge should be implemented, regional environmental factors. The multidisciplinary team approach is applicable wherever in the world, but it might be centralized, in particular in low-resource countries. International clinics can help, and cost-effective technologies such as sequencing by Sanger approaches might be utilized. With this, I'd like to thank all my collaborators who contributed to this research.
Thank you very much, and thank you for that excellent talk. Can I just ask you the first question? So in a